Bismillah ar-Rahman ar-Rahim. Actually, I was asked to give this lecture to the sixth year uh, about gallbladder disease. First of all, I should know that gallbladder disease is the commonest biliary tract disease, and you will notice in your practice that this is the commonest biliary disease, especially gallstone disease. And you will know also that cholecystectomy is the most commonly done biliary surgery, even all over the world. First of all, we have to look to the anatomy of the biliary tree, especially the gallbladder. You know that bile ducts, small bile ductules communicate with each other to larger bile intrahepatic bile ducts till it reaches to common hepatic duct, and then joins cystic duct forming the common bile duct. Cystic duct takes bile to the gallbladder, and from the gallbladder to the common bile duct. Gallbladder is a biform structure lying under the surface of the right lobe of the liver, and gallbladder point exactly correspond to intersection of the mid-clavicular line with right costal margin. Callus triangle is very important even for surgeons and for physicians. Callus triangle is the area of anomalies of ducts and of cystic artery, and usually cystic artery injury during surgery is the cause of biliary catastrophe, especially bile duct injury. Callus triangle is formed by the undersurface of the right lobe of the liver, the cystic duct, and the common hepatic duct. This triangle is characterized by the presence of biliary and vascular anomalies. Congenital gallbladder disease involve changes in the shape or position. Sometimes we have double gallbladder, and this is very rarely and usually is associated with other congenital anomalies, like, for example, annular pancreas or many other anomalies, cystic duct anomalies or colorectal cyst. You may see this anomaly very rarely, and usually it presents itself as a puzzle for the surgeon when they found the double gallbladder. Cystic duct may be Y-shaped. You may have bilobed gallbladder. Gallbladder usually it's a biform structure. Usually you find it folded, self-forming sigmoid-shaped gallbladder. It may be found completely retroserosal. You may have diverticulum at the bladder neck or fundus of the gallbladder. Hourglass gallbladder is a type of anomaly characterized by formation of stones in the distal part near the fundus. Sometimes you find the gallbladder totally intrahepatic, and this is important for surgeons. Also, gallbladder usually stuck to the undersurface of the right lobe. Sometimes you find gallbladder having mesentery, and this usually leads to a rare condition of gallbladder strangulation. The epidemiology of gallstones or gallstone disease it usually affect 10 to 20% of adult per population. It's more common in women as compared to males, and the female to male ratio is usually 2 to 1. People of advancing age, female sex with a tendency to obesity and a history of rapid weight loss are particularly prone to develop cholesterol stones. Pigment stones, on the other hand, are far more often associated with hemolytic disorders. In our country, you can say that the prevalence of gallstones is usually among 20% of the population. That's because we have about 30% of the population they are having uh, overweight or obesity. And so you will know that obesity is a risk factor for formation of gallstones as it's associated with secretion of lysogenic bile. And we mean by lysogenic bile, that's bile rich in cholesterol, which will precipitate and form stones. This is an important in clinical practice. The clinical correlation 70 to 80% of patients with gallstones remain asymptomatic throughout their lives. About 1 to 3% of these patients exhibit symptoms in any given year. The risk decreases with age. In Egypt, 20% of the population they have gallstones. Prevalence in women, as I mentioned, is twice that in men. Among cirrhotics, it's 30% more common than normal population. This because disturbance of bile acid pool. And we'll know that bile acids are very important to keep cholesterol in solution, especially orthodox colic acid. Prevalence is higher among diabetics after gastrectomy, earlier resection with hypolipidic drugs, long-term octreotide, and contraceptives. Most disorders of the biliary tract result from gallstones. Risk factors for gallstones include female sex, obesity, increased age, and Western diet. Certain drugs like contraceptive pills, anabolic steroids, and somatostatins, hypolipidemic drugs, may be associated with gallstones. Predisposing factors for gallbladder stone formation: impaired gallbladder function, supersaturated bile, cholesterol nucleating factors absorption, disturbed absorption, or disturbance of bile acid pool as a result of disturbed absorption or of intrahepatic circulation of bile acids. If you look to this slide, you find all the factors involved in the pathogenesis of gallstones. You find impaired gallbladder function, increased nucleating factors, supersaturated bile, which sometimes is genetically determined. As we mentioned, is associated with obesity, drugs, and some liver disease. Disturbed intrahepatic circulation of bile acid, as in cases of ileal resection or in cases of uh, inflammatory bowel disease, like Crohn's disease specifically, as the terminal ileum is the most common site for affection in Crohn's disease. About nucleation, the excess cholesterol must precipitate from solution as solid microcrystals. Such precipitation in the gallbladder is accelerated by mucin, a glycoprotein, or other proteins in bile. The microcrystal must aggregate and grow. This is facilitated by the binding effect of mucin forming scaffold and retention in the gallbladder from actually impaired contractility or from excess cholesterol in the bile. Nucleating factors: several specific yeast labile glycoproteins, gallbladder mucus, biliary calcium, alteration in gallbladder prostaglandin metabolism, gallbladder stasis, altered gallbladder absorption are increased nucleating factors, or they lead to many nucleating factors. Also, parasites are an important cause for nucleation because disintegrated parasites, for example, if it is Ascaris or if it is Fasciola hepatica, will be in need for precipitation of cholesterol and bile pigment and formation of gallstones. Once cholesterol crystals begin to agglomerate and form clusters, the stones are inevitable. And we'll know that the growth of stone is at a rate of 1 to 2 millimeter per year. It takes long time to have a large or huge stone. There are three types of stones that are as follows: cholesterol stones, pigment stones, brown or black stones, or mixed stones. The commonest type is cholesterol stone and represent about 85% of gallstones, especially in Western world. For cholesterol gallstones to form, bile must be supersaturated with cholesterol. Normally, water-insoluble cholesterol is made water-soluble by combining with bile salt, specifically the orthodoxocolic acid and also lecithin, which is a phospholipid, to form mixed micelles. Supersaturation of bile with cholesterol most commonly results from excessive cholesterol secretion, but may result from a decrease in bile salt secretion or lecithin. Black pigment stones are small and hard stones composed of calcium bilirubinate and inorganic calcium salts. Factors that accelerate their development include alcoholic liver disease, chronic hemolysis, and older age. Brown pigment stones are soft and greasy, consisting of bilirubinate and fatty acids. They form during infection, inflammation, and parasitic infestation, and usually above bile duct structure. Symptoms and the signs of gallstone disease: about 80% of gallstones are asymptomatic. The remainder have symptoms ranging from biliary type pain or cholecystitis to life-threatening cholangitis. Biliary colic is the most common symptom. Gallstone migration into cystic duct, which even if transient, causes biliary pain or biliary colic. Biliary pain characteristically begins in the right upper quadrant but may occur elsewhere in the upper abdomen, maybe in epigastrium, maybe in left hypochondrium, and usually it radiates to the back, to the right shoulder, maybe to retrosternal region. It's often poorly localized, particularly in diabetics and the elderly. The pain may radiate into the back or down the arm. Episodes begin suddenly, become intense within 15 minutes to 1 hour, and remain steady for up to 12 hours. And usually, this pain is severe enough to send the patient to the emergency department for relief. Nausea and vomiting, like any visceral pain, usually biliary pain is associated with nausea and vomiting. And these manifestations are considered as a manifestation of autonomic nervous system disturbance, which are associated with any visceral pain. But fever and chills don't occur unless cholecystitis has developed. Mild right upper quadrant or epigastric tenderness may be present. Peritoneal findings usually are absent, and this is important to differentiate between uh, acute cholecystitis and other abdominal emergencies. And you should know that signs of peritonealism include tenderness and rebound tenderness. Rebound tenderness is not seen in cases of acute cholecystitis as it is an acute emergency or acute abdomen. Clinical findings: shallow respiration, fever, jaundice, positive Murphy sign, and you should know what's meant by Murphy sign. Murphy sign is the point of intersection between the mid-clavicular line and the right costal margin. This point corresponds to the gallbladder fundus. Tender mass at the gallbladder region or increased leukocytic count. And here it's important to notice that increased leukocytic count actually is very important. If you find polymorph leukocytosis, it indicates bacterial infection. But if you find eosinophilia, you should suspect parasitic infection or parasitic infestation of the gallbladder. As we mentioned, biliary pain can follow a heavy meal, fatty food, and is usually precipitating factor considered as precipitating factor the large meal or fatty meal. Uh, Little correlation exists between the severity and the frequency of biliary pain and pathological changes in the gallbladder. Biliary pain can occur in absence of cholecystitis should pain last more than 12 hours, particularly if accompanied by vomiting or fever. Acute cholecystitis or pancreatitis should be suspected. And usually we recommend analysis of the pain. If you find pain mainly in the epigastrium radiating to the back, you have to suspect migration of stone into the common bile duct or associated pancreatitis, which is called acute biliary pancreatitis because it entails obstruction of the common bile duct and pancreatic duct. This is an example for multiple stones in the gallbladder and cystic duct. The prognosis: those with asymptomatic gallstones become asymptomatic at a rate of about 2% per year. The symptom that develops most commonly is biliary pain rather than a major biliary complication. Once biliary symptoms begin, they are likely to recur. Pain returns in about 20 to 40% of patients while about 1 to 2% of patients usually develop complications or what we call gallbladder catastrophe, such as cholecystitis, choledochocolitis, cholangitis, and gallstone pancreatitis. Acute and chronic cholecystitis in 96% of cases, cystic duct obstruction is noticed in acute cholecystitis. And acute cholecystitis with recurrent attacks will turn to be chronic cholecystitis with resultant fibrosis of the gallbladder wall. The clinical features: sufferers are often obese, fertile female over 40, pain occur late at night in the right hypochondrium, epigastric region referred to right shoulder. Digestive symptoms: flatulence, nausea, and vomiting may be associated. Fever if there is secondary biliary infection. And we'll know that obstruction of cystic duct may be associated with mucocele of the gallbladder. If it gets infected, it will be biocele of the gallbladder. Acalculous cholecystitis, 5 to 10% of acute cholecystitis in adults, usually 30% in children. Factors associated with critical conditions after major surgery, multiple injuries, major burns, severe sepsis, and usually it's noticed in patients on mechanical ventilation. Bacterial infection with typhoid bacilli, actinomycosis, it's very rare nowadays, and at the time, typhoid bacilli, its presence in the gallbladder was found or was reported to be associated with gallbladder cancer. Parasitic cholecystitis, it's important to know about it because in our country we have fasciolitis, is endemic in our country, and usually it's associated with peripheral eosinophilia and gives classic picture of cholecystitis with fever and eosinophilia. Another example or rare type of cholecystitis is emphysematous cholecystitis. And we mean by emphysematous cholecystitis when you do X-ray or just plain X-ray, you find air in the gallbladder. This indicates emphysematous cholecystitis. It's a rare type. It's seen in immune-compromised patients and usually in association with infection with gas-forming organisms, especially Clostridia wilchi. Treatment of gallstone disease is just to remove the gallbladder after preparing the patient by analgesics and antibiotics. However, if symptoms occur, removal of the gallbladder will be alleviating for pain, and it's the gold standard for management of gallstones. And usually we recommend removal of symptomatic gallstones. We should not leave symptomatic gallstones because symptomatic gallstones are symptomatic gallstones or gallbladder stones. Usually they will be followed by complications rather than the silent gallstones. Whether it's two types of surgery nowadays we have, whether it's open cholecystectomy or laparoscopic cholecystectomy, it depends on the experience of the surgeon and choice of the patient. As we mentioned, cholecystectomy is effective in alleviating symptoms of the patient. Some patients develop diarrhea, often because of bile salt malabsorption in the terminal area. Is unmasked. Prophylactic cholecystectomy in a symptomatic patient with cholecystitis is not warranted except in those with quite large gallstones or those with calcified gallbladder, porcelain gallbladder, and usually it's mentioned in the literature that porcelain gallbladder is a precancerous condition. That's why it should be removed because of an increased risk of gallbladder carcinoma. Of course, asymptomatic gallstones, especially in diabetics and in association with huge stones, should be removed. In diabetics, because they are liable for infection, they are liable for complications more than normal population. Large gallstones should be removed because large gallstones in the gallbladder actually irritate the gallbladder epithelium, producing cholecystitis, metaplasia, dysplasia, and at the end they are usually associated with gallbladder carcinoma. At the time, there was a method of treatment that's stone dissolution, especially cholesterol gallstone dissolution. And to to approve that the stones are cholesterol, you have to do CT scan examination to exclude calcification of the stones. And you should know that a CT scan is 50 times more accurate for detection of calcification, and you have to aspirate the duodenal bile to see cholesterol crystals. And usually it's done by inserting a pigtail caster into the gallbladder with injection of a substance called methyl tertibutyl ether to dissolve cholesterol stones. That's confirmed by injecting contrast into the gallbladder under screen. Sometimes we say medical dissolution of gallstones in small stones less than half centimeter in diameter, and usually the patient is given orthodoxycholic acid for 6 months in a dose from 10 to 15 milligram to dissolve such a stone. Complications of gallstone disease: acute cholestasis, cholangitis, chronic cholestasis, gallbladder cancer, mucocele of the gallbladder, biocele of the gallbladder, ruptured gallbladder, acute biliary pancreatitis, obstructive jaundice, Mersey syndrome, Beauvais syndrome, and gallstone disease. Mersey syndrome is obstruction of the common bile duct by a large stone impacted at the neck of the gallbladder. What is its importance? Beauvais syndrome is not uncommonly associated with gallbladder cancer. Beauvais syndrome is fistulization of the gallbladder with the duodenum, with passage of large stone. This large stone will obstruct the gastric outlet, leading to gastric outlet obstruction. Gallstone ileus is another complication due to fistulization between the gallbladder and the small intestine, and usually you find the stone impacted at a loop of jejunum or at the terminal ileum, the most narrow part of the small intestine, leading to intestinal obstruction. That's called gallstone ileus. Gallstone ileus leading to acute intestinal obstruction, and Beauvais syndrome leading to gastric outlet obstruction. How to diagnose gallstone ileus? It's very interesting to know that when there is fistulization between the gallbladder and the intestine, you will find what we call aerobilia. Aerobilia means air in the biliary tract. You will find delineation of the bile ducts by air. If you look to this picture, it's an interesting picture of uh, gastrine follow through or follow through examination of the intestine by giving the patient oral gastrine. Gastrine is swallowed, and this is the stomach, and this is the duodenum. And if you look here, you find delineation of the biliary tract. You find aerobilia. This will clinch the diagnosis, and then you find that large stone is impacted here in the small intestine, producing intestinal obstruction. And this is the stone after being extracted during surgery. If you look to this slide, you find that it represents all complications of gallstone disease. If we have numerous small stones, you will have chronic cholestasis with calcified or with fibrosed gallbladder wall. If we have huge stones like these stones at the neck of the gallbladder, you have to suspect the presence of gallbladder cancer, as you see here in this. This is the type of pain you can see in cases of cholestasis: right hypochondrial pain, epigastric pain radiating to the sternum or radiating to the back, to the right shoulder. And if it is epigastric, you have to suspect the presence of biliary pancreatitis, which is due to impaction of stone at the papilla of water, producing biliary obstruction and pancreatic duct obstruction. Diagnostic tools: clinical picture, ultrasound examination is very accurate for detecting gallstones. Cholecystography, it's obsolete nowadays. CT scan examination can be done for detection of tumors. MRCP for evaluation of the biliary tree or biliary tract to find stones, to find strictures. ERCP, usually it's done as diagnostic and therapeutic procedure in some cases of biliary pancreatitis or bile duct obstruction. If you don't have any of these, you can do PTC, which is percutaneous transhepatic cholangiography. This is a classic picture of gallstone, as you see here. It's a sagittal section of the ultrasound. You can see skin, you can see uh, subcutaneous fat and muscle layer, and you can see peritoneum, and you can see gallbladder stuck to the undersurface of the right lobe with echogenic structure casting posterior shadow. This is the classic picture of gallstone. You may have one stone, you have more than one stone, and if you find the gallbladder studded or fully uh, studded with stones, you find a crescent that's casting posterior shadow. Biliary mud, you can see it like that, second gallbladder wall with sediment on the gallbladder wall. This biliary sludge is important to report because it may be a cause of symptoms of biliary pain or biliary obstruction or even pancreatitis. MRCP, if you look to this picture, it's very interesting because it's a case of MRCP, magnetic resonance cholangiopancreatography, for a case of perforated gallbladder, which is very rare. You can see the stomach, duodenum, and distal common bile duct stricture with biliary dilatation and uh, ruptured gallbladder at or perforated gallbladder at the fundus of gallbladder with spillage of fluid outside the gallbladder. This is a case of Merisi syndrome, large stone at the gallbladder neck, and this is a type of congenital anomaly known as hourglass gallbladder. This is a single floating stone in the gallbladder. It's called gallbladder solitaire, and usually it's called stereo stone since it's floating in the gallbladder. Numerous stones in the gallbladder during ERCP was impacted one at the distal end of the ampulla of water, and sometimes biliary fasciitis is mistaken for gallstones. And discover this while you are extracting the filling defects seen during ERCP. You find it fasciula hepatic. Differential diagnosis, usually it's an acute abdomen. You can diagnose it with the clinical picture and the ultrasonography. It should be differentiated from appendicitis, perforated peptic ulcer, intestinal obstruction, pleurisy, myocardial infarction, first aid treatment, antibiotics, analgesia, antibiotics, antispasmodic, and surgery. Sometimes you have problems after cholecystectomy, usually due to wrong diagnosis before surgery, or due to papillary dysfunction or stenosis, or you have IBS. The patient may have IBS, and you remove the gallbladder, and you find the patient is still complaining of uh, abdominal pain and biliary stones due to missing during surgery. And this is an example for missed stone during surgery with T-tube in the common bile duct. And you may have what's called biloma, and it's due to bile leak of bile outside the bile ducts after surgery. It should be drained, of course. This is how we extract the gallbladder stones using the endoscope and sphincterotomy. The questions you may be asked, this list is the list of questions that you may be asked about gallstone disease. Then we'll talk about a few slides about pancreatitis. Then we'll come to pancreatitis. We'll start by acute pancreatitis. Acute pancreatitis is a discrete episode of inflammation resulting from intrapancreatic activation of digestive enzymes. It is a disease of wide spectrum of severity and complications and outcome. It may be just mild acute pancreatitis, which is resolved without any residual effect, up to severe pancreatitis with pancreatic necrosis. Spectrum of the disease: acute edematous or interstitial pancreatitis, mild, self-limited in most patients. Inflammation results in edema of the pancreas. Parenchymal damage is minimal. Pancreas recovers after the attack. Hemorrhagic or necrotizing pancreatitis may be very extensive, progressive, result in coagulative necrosis of the pancreas and surrounding tissue. Autodigestion of the organ leads to hemorrhage. The mass of inflamed pancreas and surrounding tissues is phlegmon. Complication: widespread inflammatory process. Any of the following organs might be affected: common bile duct, duodenum, transverse colon, splenic artery, and vein. Spleen, actually pararenal space, lesser sac, posterior mediastinum, abdominal wall, and diaphragm. Peritoneal serves leading to pancreatic ascites. Complication leakage of protein-rich fluid from the systemic circulation into peritoneal and retroperitoneal space lead to hypovolemia and shock. Systemic effects of this material include cardiovascular instability, respiratory failure, and renal failure. Hemorrhage usually is characterized by the presence of Cullen sign or Turner sign, which Cullen sign means pigmentation around umbilicus, while Turner sign means pigmentation in the flanks as a result of uh, hemoproteinemia in such cases, and disseminated intravascular coagulation due to release of cytokines. There will be disseminated intravascular coagulation. Pseudocyst formation, pancreatic abscess, fat necrosis, polycystitis, and adult respiratory syndrome, and this is an indication for ventilation, and the patient must be admitted to the intensive care in severe cases. Pulmonary alveolar capillary membrane may be disrupted, forming hyaline lining of the alveoli, leading to hyaline respiratory disease like that in children. Uh, Etiology, alcoholism is not common in our country. Biliary tract disease is the commonest cause in our country. Sometimes you find uh, acute pancreatitis associated with severe hyperlipidemia, especially uh, triglyceridemia, hypertriglyceridemia. This is an important cause for acute pancreatitis. Surgical trauma actually is important, and the blunt abdominal trauma, ERCP. If you do ERCP at the beginning and you play too much with the papilla of water, it will lead to papillary edema, which may be a factor for acute pancreatitis. Or if you inject the contrast forcibly into the pancreatic duct. Infection, like viral infection, any viral infection can be associated, and commonly it's associated with mumps, for example, mycoplasma, salmonella, mycobacterium, and cryptosporidium. These are rare infections. Metabolic disorders like hypertriglyceridemia, hypercalcemia, and drugs can induce actually pancreatitis, like what's called drug-induced vasculitis and pancreatitis. Anatomical abnormality like annular pancreas, colorectal cyst, or penetrating peptic ulcer. There may be parasites, especially what's famous to cause pancreatitis. It's Ascaris wars because it likes to move and pass through pancta. Usually it passes through the papilla of water, producing papillitis and pancreatitis. Drug-induced pancreatitis, acute pancreatitis, is very similar to drug-induced hepatitis. Nearly the same drugs, sulfonamide, estrogen, tetracycline, furosemide, isanolamine, mesanolamine, and rifampicin, metronidazole, and erythropoietin. Clinical criteria for severe pancreatitis, usually you find cardiac manifestation, blood pressure will be less than 90 millimeter mercury, and tachycardia, ECG changes, pulmonary dyspnea, and you find other respiratory distress syndrome if you have hypoxia and you find PO2 less than 60 millimeter mercury. Renal output less than 50 milli per hour. Metabolic calcium, you find hypocalcemia and hypoalbuminemia. Hematological findings in the form of disseminated intravascular coagulation with falling hematocrit, abdominal distension due to pancreatic ascites, tetany with subcutaneous fat necrosis, which is commonly seen around the legs. Laboratory tests, elevated serum amylase and lipase. Actually, serum amylase noted within 24 hours and persists for 3 to 5 days, while serum lipase persists for up to 10 days, especially urinary amylase. Leukocytosis, hyperglycemia, jaundice, and arterial hyperemia. Radiologically, the Dublin film of the abdomen standing, you found what's called sentinel lobe. Sentinel lobe, it's a dilated jejunal lobe over the pancreas, which shows actually air fluid level. If you find air under diaphragm, it means perforation of a gut. Ultrasonography, normally the pancreas is more echogenic than the liver. If you compare the echogenicity of the pancreas to the liver and you find it hypoechogenic as compared to the liver, it indicates pancreatic edema. CAT scan examination is the best way to evaluate the occurrence of pancreatic necrosis and to do stages or staging of severe pancreatitis. ERCP is indicated for management of acute biliary pancreatitis, and in certain centers in acute non-biliary pancreatitis, usually they try to put pancreatic stent, but this is not popular and not actually done everywhere. Differential diagnosis of acute pancreatitis, acute cholestasis, biliary colic, cholangitis, perforated viscous, acute hepatitis, acute intestinal obstruction, and mesenteric venous occlusion. Treatment 90% self-limited in cases of mild pancreatitis, and usually there is what's called Atlanta classification of acute pancreatitis. It includes or it entails classifying pancreas into mild or severe pancreatitis. If it is mild, it's just pancreatic edema. If it is severe, you find pancreatic necrosis, and this indicates that it's a severe case of pancreatitis. You give analgesia, you maintain intravascular volume, and monitor vital signs and complications. Drug treatment and nutrition support in cases of acute pancreatitis. BBIs or proton pump inhibitors, somatostatin or its analog, uh, sandostatin or octreotide. Why should we give BBIs for patients with acute pancreatitis? It has been found that these patients are liable to have gastric and duodenal ulceration, what's called curling ulcers, as an acute or as severe emergency or severe acute condition. Prophylactic antibiotics, actually intralipid, it is not recommended nowadays to give intravenous or, or parenteral nutrition. It's recommended to start enteral feeding in such patients to prevent translocation of bacteria from the intestine and colon to the necrotic pancreas. And it's an important factor to have infected necrosis of the pancreas. It has been found that enteral feeding through nasogastric tube or jejunostomy tube is much better than uh, intravenous nutrition. Initial high carbohydrate diet, low protein and fat is recommended. For severe cases, you have to admit into the intensive care. Necrosectomy may be done either endoscopically or surgically. Nowadays, it's not done surgically. Usually, it's done by endoscope. And for this, it can be done by a laparoscope or it can be even done by upper endoscope through a fistula that's created between the stomach and necrotic tissue. Pancreatectomy is rarely done. Decompression of biliary tract, usually nowadays it's done by endoscopy. CD-guided percutaneous drainage of necrotic pancreas or endoscopic drainage also may be done in some cases. You should remember that for acute biliary pancreatitis, urgent endoscopic sphincterotomy is a must as soon as possible within 72 hours of onset of symptoms to avoid occurrence of pancreatic necrosis. Some examples of acute pancreatitis, if you look to the tail of the pancreas, you find that it's hypoechoic as compared to the liver with some fluids and stratification of fat around it. This is how biliary pancreatitis is produced. It's due to impaction of stone at the papilla water, as I mentioned, and this is how we do endoscopic sphincterotomy and extraction of biliary gravel. Chronic pancreatitis results from progressive destruction of the pancreas by inflammation and fibrosis, very similar to liver cirrhosis or chronic hepatitis. It starts as acute hepatitis to chronic hepatitis and then liver fibrosis. The same for acute pancreatitis. Recurrent attacks will lead to destruction of the gland or the pancreas, and then it's replaced by fibrosis. Exocrine pancreatic tissue and function are lost earlier. You find the patient presenting with steatorrhea. rather than diabetes mellitus, followed by endocrine parenchyma and function that will be manifested as diabetes mellitus. The classification will have obstructive chronic pancreatitis due to tumor or scar of parenchymal inflammation, congenital anomalies, or infiltrative and autoimmune type such as hemochromatosis and Sjogren's syndrome. Chronic calcific pancreatitis associated with alcohol or cigarette smoking, hyperparathyroidism, and hereditary autosomal dominant chronic pancreatitis, it's precancerous condition, and in association with cystic fibrosis. Clinical presentation, abdominal pain, malabsorption, vitamin B12 deficiency, diabetes mellitus, and obstructions. Physical examination, you find epigastric tenderness, you have mass or cyst in the epigastrium, weight loss, and bleeding tendency with jaundice. Diagnosis, you ask for serum amylase and lipase, and if the patient is beyond 72 hours or 3 days, you ask for urinary amylase. Increased fat in the stool, you find that there is fat in excess more than 30 to 40 gram per day in the stools, and this indicates steatosis or steatorrhea. Ultrasound and CAT scan, ERCP, and EUS in certain cases of chronic pancreatitis, and sometimes it's difficult to differentiate chronic pancreatitis from a case of pancreatic cancer. You should, in this case, you should do EUS, which allows you to take biopsy from pancreas safely. Treatment, stop alcohol or tobacco. You have to activate feedback control by giving orally. You give excess doses of pancreatic enzymes to make the pancreas rest, and this will is known as feedback control. Percutaneous injection of alcohol to alleviate pain in certain cases of chronic pancreatitis. You denervate the pancreas by ablation of the stellate ganglion, and surgery, including pancreatectomy in some cases. Drainage procedures like stenting, for example, in chronic alcoholic pancreatitis with pancreatic duct strictures, you resort to putting stents in the pancreatic duct. Acid suppressive therapy is important, as we mentioned, and nutrition support. Few words about pancreatic cancer. Exocrine pancreatic cancer account for 95% of pancreatic cancer. 85% arise from pancreatic duct epithelium, and usually 5% only from the islet tumor cell. Manifestation or manifest themselves by hormones they secrete. Tumors may secrete gastrin, insulin, glucagon, VIB, vascular intestinal peptide, and pancreatic peptide, somatostatin. All these can characterize the endocrine part of the pancreas or endocrine tumor of the pancreas. Warning signs of pancreatic cancer: unexplained recent upper abdominal pain with retroperitoneal lesion, jaundice with weight loss more than 5%, unexplained acute pancreatitis, and unexplained acute diabetes mellitus. If you look to this ultrasonography, it shows you that markedly expanded head of the pancreas with dilated pancreatic duct in a case of a huge pancreatic duct tumor. And here, if you look to CT scan examination, which is very important for diagnosing and staging pancreatic cancer, you can see pancreatic cancer at the head of the pancreas with dilatation of the pancreatic duct at the body and tail of the pancreas. An example for calcification at the pancreas, and usually these calcifications are dystrophic calcification or maybe due to pancreatic stones. We may have pancreatic stones in very rare condition. Diagnostic tools of pancreatic cancer: CA19-9 cancer antigen 19.9, CEA or carcinoembryonic antigen, ultrasound examination for focal pancreatic lesions, and usually we say that if you have focal pancreatic lesion, it is tumor tail proved otherwise. CT scan examination, very important actually for diagnosis and staging of pancreatic cancer. You have to do CT scan exam to evaluate encasement of the vessels around the pancreas, especially portal vein or celiac artery. And this is very important. It's called assessment of resectability of the tumor. Angiography is important in certain cases. Fine needle aspiration may be done. And what's more important is EUS. And a recommendation for EUS biopsy, if the patient is amenable for surgery or candidate for surgery, you should not do biopsy. But if the patient is unfit for surgery and you are planning to treat the patient medically, give the patient oncologic treatment, it can be submitted to EUS with biopsy intake. Laparoscopic evaluation before surgery in certain centers, they do laparoscopic evaluation because laparoscopy is the best way to discover peritoneal seedlings, which will not be seen by any other means. Magnetic resonance imaging actually can be used also for evaluation of resectability. Treatment option surgery is the best if early, 5% only are resectable. Chemoradiation is another option, and it's another method for downstaging of the case. And we should know that pancreatic cancer is very aggressive. Palliative drainage, endoscopic like stenting, for example, if it is not feasible, we can do it percutaneous or surgical, which includes surgical bypass for the biliary tract and for the stomach to avoid gastric